BGU Radio.
This podcast is a production of Ben-Gurion University's Global Health Summer Course, hosted by Professor Nadav Davidovitch and Dr. Anat Rosenthal. BGU Global Health, where health goes global.
Hello, so we are today in another podcast for our course on global health. And today we are going to speak with Professor Moran-Gilad. He will soon present himself. I must say that we are working together for many years on different public health issues. So, Kobe, it's a pleasure to be with you today. And maybe let's start, if you can present yourself and also about your work in recent months. We were a bit disrupted by Black Swan called COVID-19. So Kobe, again, thank you for being with us, and the floor is yours.
Okay, thank you, Nadav, for the invitation. It's really a pleasure to speak to you today. And yes, I will start with a brief self-introduction. So I'm a physician. I specialized in clinical microbiology and infectious diseases, and I'm currently a professor at the Department of Health Systems Management at the Faculty of Health Sciences, School of Public Health at BGU, and also practicing as a physician in clinical microbiology. So obviously, I'm interested in pathogens, not only coronavirus, but any emerging pathogens and public health threats. And my involvement in COVID-19 is related. First of all, we do academic research, and of course, the hospital is very busy with responding to such an incident, but also at the national level. So for the last decade or so, I've been a member of the National Epidemic Management Team. So this is an advisory body that supports the national preparedness and response to epidemics and pandemics. And the EMT has been obviously very active since the early beginning of the incident, even before we had the first cases in Israel. And on the international level, I have quite a few collaborations. So we are also doing different stuff related to COVID-19. And I'm also the program director for ESCMID, which is the European Society for Clinical Microbiology and Infectious Diseases, and our annual congress, ECMID, which attracts up to 15,000 people every year, has been cancelled because of COVID-19. So I'm also severely affected by COVID-19, but now we are planning to organize an online conference that is going to be called ECVID, so the European Conference on Coronavirus Disease, and that is planned for end of September, and it is taking a lot of my time, but it's also a great privilege to be able to deliver an international congress dedicated to COVID-19.
So you just mentioned one of the implications of COVID-19. By the way, this course also this year is an online course, including using this podcast. I think you are in a very unique position since you are both a public health physician and also have the expertise in microbiology. So you're one of the bridges, I'd say, between the laboratory, clinical, and public health policies. So if you can tell us a bit about this unique position, let's say in regular times, and also how this position now being influenced by COVID-19 personally, and maybe also on a larger scale. As you mentioned, you are involved both in national and international research and policy making.
Yeah, it's a good point. I mean, traditionally, epidemiology and microbiology are quite siloed, so they don't speak to each other quite often. And although these are two professions that at the end they have shared goals, it's very difficult to actually create a crosstalk between the different disciplines, because the epi folks are usually either physicians or maybe they originate from other disciplines, but they're field persons and they look at numbers and they do investigations, whereas the lab folks are very much oriented toward holding pipettes and doing lab work. And these are different languages, and it is indeed a challenge to bring together the two disciplines and make them speak to each other and identify the complementarity between the two topics, because obviously this is a cycle. In laboratory medicine, we refer to the diagnostic cycle, and the diagnostic cycle starts by the physician asking a question and ordering a lab test. And of course, after the test is being performed and reported back to the physician, it needs to be interpreted. And commonly the interpretation, and in public health microbiology, this is quite significant. You need this dialogue between the lab and epi persons to actually make sense out of the data and translate the laboratory results into public health action. So I think this was my main motivation in pursuing training in both aspects. I'm always proud to say that I'm the only physician in the Middle East who has done both specialties, but actually also on a global scale, it's not very common to see people who trained in both. And personally, I would like to see more and more people do that, because I think it's very important to have this dialogue between the professions.
I think maybe in an outbreak, and this is also based on my experience as a physician epidemiologist, doing field epidemiology is one of the places that actually you can see more collaboration. And you spoke about the people in the laboratories. So in these cases, when you have an epidemiological team, you see also laboratory people going outside to the field. This has, of course, professional implication, but maybe also technological implication, because then you need to develop on-site tests. And I think that during COVID-19, this was also a very important aspect. We remember that both in Israel and other countries, the question of testing became very lengthy discussion. And it seemed to me that many times people involved in this dialogue maybe were speaking different languages, and there was kind of miscommunication. So it's even saying how some people like you are even more important, kind of translating between. So I wonder how you see this whole thing that was evolving in the COVID-19 outbreak.
Okay, so I think COVID-19 brought some very interesting developments when it comes to public health microbiology and how it integrates in pandemic preparedness and response. I would say it's nothing new, because we had pandemics before, we had outbreaks before. Microbiology and virology did not start just yesterday, but I think there are some features of the pandemic which emphasized some of the gaps and challenges in that respect. First of all, is the need for rapid development of diagnostics. So on one hand, we can say that what happened in COVID-19 was unprecedented with respect to the number of different assays that have been developed and approved over a very short period of time. And this is, of course, very encouraging because testing capacity was urgently needed. But on the other hand, we witnessed difficulties in performing quality control. So many tests that have been developed and deployed did not perform as well as expected. We ended up in the situation, again, on a global scale, but sometimes also on a national scale, that different tests are being used. And this creates a problem of harmonization of results, because the same individual could be tested twice in two different labs and get different results. And of course, when we try to create a national, regional, and global snapshot of how many cases are there, what is the dynamic of the outbreak, calculate the reproduction number, and so forth, we need data. And if our data are based on lab results which are non-congruent or disharmonized, then we have a big issue. And one thing that I think emerges from this outbreak is that we need to have an agreed global approach on how to develop tests for pandemics, not on the technical side, because we have many good scientists and also the industry, they can do that very well, but how this needs to be organized. And it is possible that some regulatory bodies or international governmental organizations need to take care of that. And we actually published a few weeks ago an opinion paper in BMJ exactly on that. So touching upon the challenges associated with the harmonization or lack thereof when it comes to tests. So this is one point. A second point is that we could definitely see different ideologies when it comes to laboratory testing. So some people advocated that there needs to be massive testing, and we saw some countries which performed very well in that respect, and it is still arguable what is the added value of this testing on the long run for controlling COVID-19. And then other countries did not use testing massively. In some cases, that was because lack of capacity. And of course, in developing countries, like in Africa, for example, in South America, in some Middle Eastern countries, we saw lack of cases, and that could be, at least in part, be attributed to insufficient testing. But in some countries, there was a reluctance to actually deploy massive testing. But I think in most of them, at the end, they understood that they need to test massively. I think even the US was a bit behind when it comes to massively deploying testing. And another point is point-of-care tests. So we are using point-of-care tests for a long time now in microbiology. But I think there is one application of point-of-care tests which are beyond traditional diagnostics that has been part of the discourse in COVID-19, and that is the use of point-of-care tests to rule in, rule out cases in order not to better treat people, but in order to ignite the economy. And this is an approach for testing which was not very notable in the past. So how tests could be deployed in order to allow people to continue their daily dues.
It's very interesting now also to see the whole discussion about air travel and how maybe testing would be involved there. But I want to return to your comment that I think is very important for our course, and this is the question of harmonization. And you spoke very broadly. Can you be more specific and tell us a bit, because I can think about the World Health Organization, I can think about WHO and their tension with the CDC or ECDC, but I know that are also professional organizations like some of those you are involved. So if you can tell us a bit about this kind of international world, and of course there is also private money here. So if you can tell us a bit about this question. There are lots of discussion now about patents, and this is not just about testing. Of course, it's also about a vaccine. So if you can give us a bit of a flavor about this harmonization, both about tests and maybe other diagnostic or and even vaccines that are going to be developed.
Okay, so this is actually quite complex. First of all, maybe we can start by referring to the molecular diagnostics, which is the most widely used diagnostic strategy for COVID-19. So PCR-based tests that aim to detect the presence of the virus in clinical samples, especially respiratory samples. And basically, such tests could belong to one of two big groups. So either in-house assays. So these are assays which are home-brewed, self-developed, and self-validated. And of course, they could be adopted by other users. And commercial tests. So commercial tests use different kits. Some are more open, some are strictly black box, but they are kittified. And early in the course of the pandemic, the first assay that has been developed, and that was a joint effort by several European countries, mainly the UK, Netherlands, and Germany. So that was a homebrew PCR, and that PCR was developed based on the first genome sequences of the virus that have been released from Wuhan. Of course, there were some Chinese assays that were also developed and used locally. Some of them are now being used also outside China. And so this homebrew PCR was then adopted in quite a few countries. Also in Israel, it was the primary assay that was adopted by the Ministry of Health. Now, there are many pros and cons to using in-house versus commercial assays, and I don't think we have time to really dive into that, but just to say that homebrew assays are usually more fit for purpose, and they allow the user flexibility, but at the same time they also carry many risks with respect to quality control, and they require more expertise to operate and to maintain, whereas commercial assays are much more robust in that aspect. And I think there is a continuous tension, and we also felt that tension in Israel, but I'm aware that it also happened in other countries, between the need to have a centralized mechanism that oversees testing capacity, the diagnostic tests, and also managing the results, as opposing to a sort of open system which allows every player to get whatever test they want depending on their needs, capacity, and so forth. And this tension is intensified when you have such a significant incident like an emerging virus. And I think that what we saw in COVID is that in many countries, government was trying to hold things until a certain point where it became really impossible to keep everything working under government, and then things were gradually decentralized. In some countries like Germany, there was a very liberal approach to begin with, and I think one of the reasons why Germany did quite well in that outbreak, of course, they have a very strong health system and ICU capacity, but also they were able to track and diagnose cases very early in the course of the pandemic, and this is because they had a massive deployment of testing capacity, which was decentralized. So I think that model could work. In Israel, we ended up also having a somewhat decentralized system, and I think this decentralization is also responsible for the challenges of harmonizing. And in order to maintain the harmonization, at least at the local level, so government could introduce some regulatory aspects and maybe approve specific assays, but that requires capacity from the side of government. So to do rapid evaluations for commercial tests, it's not such an easy task. And also it requires a central reference mechanisms, which either on a random basis or based on referral is performing ongoing confirmatory testing to actually maintain a somewhat harmonized system. And such a setup or a framework is quite difficult to initiate during the course of an outbreak. So you need to have such a system in place beforehand in order for it to perform well. So I think this is one aspect of harmonization, but of course I can speak to this in much more. Yeah.
Great. I want in the last part of our conversation to discuss maybe the broader implication for the scientific community. We had already some both personal discussion and some webinars that we participated in. It's quite clear that we are facing now a huge amount of papers that are being there outside in pre-publication forms, journalists that are being exposed, to marvelous cures and new vaccine, etc. And then after 1 week, you see that this whole thing was actually not exactly peer-reviewed, etc. So I wonder what is your take about this whole process?
Yeah, I think you're right. And as part of the COVID infodemic, we also have significant implications also to academic research and scientific communication. And this really impacts every aspect of scientific communication and dissemination that we know. So if we're looking at scientific publications, definitely there is an explosion of scientific papers. Notably, many journals now accept papers which are quite premature and in other circumstances, such papers would have never been accepted for publication. But there is the tension between withholding information, because you think, okay, this could save lives, we need to disseminate this as soon as possible. But on the other hand, if it's not a very robust scientific study, then it could actually be harmful. And I think the hydroxychloroquine is a good example for this issue. And most journals, even the most prestigious one, are keeping all the COVID-19 papers open access, which of course supports dissemination. And this is a good thing. I mean, that even journals that have been traditionally quite reluctant to allow open access, they now do it. And of course, we have the preprints. So preprints is nothing new. Bioarchives, medRxives, these have been going on for quite some time. But it became really almost a default for people on how to communicate preliminary results. And I think one of the problems is that many colleagues, not to mention the lay public and also news reporters, sometimes they fail to understand the difference between a peer-reviewed journal, be it printed or online, and a repository for preprints. And too often those preprints are communicated as facts. And it's very difficult to go back. And at some instances, it even generates scientific discussions and what I call the crowdsourced peer review. So you have this preprint going in bioarchives, and then the authors they also tweet about it, and then in Twitter it becomes viral. But then scientists start questioning and say, well, this is not peer review, so let's peer review that. And then you have dozens of scientists actually reviewing this paper and posting different reservations. And in some severe cases, it ended up with those preprints being retracted. So it's a very disorganized way of communicating things, which again is very typical of an outbreak situation. And there are pros and cons for...
But maybe much more open and public than the usual typical peer review process that we know has also its own problems.
Yeah, of course. I mean, we need to get used to that. And I mean, on a personal note, I'm one of the editors of Eurosurveillance, which is a well-known journal in the field of epidemiology. It's published by the European Union, by ECDC. And Eurosurveillance has, for many years, a publication track which is called Rapid Communication. And as an editor, when I'm handling rapid comms, these are usually papers that concern an ongoing outbreak and something that we need to communicate very quickly to the scientific community, so for other countries to be ready. And when we receive rapid communications, we handle those, including peer review, within 48 hours. So as an editor, this is quite onerous, but I'm mentioning that to say that we had and we still have proper ways of doing a very robust peer review in an expedited manner. And I think what happens in COVID is that things occasionally they're not controlled enough, and I think we can improve that. Also, we mentioned scientific conferences. I think one very striking example is that on one hand, many congresses that have been like the leading ones in the respective fields have been canceled because of COVID-19. and you end up having a wide array of online congresses, webinars, whatever. And, with Zoom and the likes of, everyone can organize a conference. So you don't need to be part of an elite group of scientists to be invited to talk. So everyone can talk and everyone can get invited to a seminar. Now, that is, of course, good because more opinions and more people are generating knowledge and discussions. But on the other hand, it's, again, not very well controlled. So, and it also reflects on the media. So many news reporters have now become experts in epidemiology. So I think for me, and this is a question that I'm asking every day during COVID, is what makes one an expert in coronavirus? And I'm still not sure about the answer.
Wow, thank you so much, Kobi. I think one of the key messages that I'm taking here is thinking about continuities and discontinuities before COVID-19 and after, because as we started our talk today, there were many things that were going on before. I just need to say, for example, you are dealing and we are working together, for example, on the antimicrobial resistance, this whole tension between the laboratory people and the epidemiologists that we started our discussion, the whole question of on-site testing, harmonization, and the peer review process, of course, were things that were discussed before, but it seems now that, like in many other issues, such as doing reform in the medical system, home care, etc., things discussed before.
Social disparities.
It would be very interesting to see, I think, only in retrospect, maybe several years from now, what is actually going to be the long impact of this pandemic. I'm sure there are going to be lots of impacts, but we're still in the middle of it, and it's interesting to continue and reflect it. So thank you so much, Kobi. It was fascinating, and I'm sure we'll continue our discussion.
Okay, thank you, Nadav.
BGU Radio.